So today I'm going to be covering the second topic from chapters in clinical psychology. I've already posted one some time back on impulse control disorders. This one is technically the first one that appears in order if you look at it from 5 chapters in the textbook, and this is on schizophrenia. So if you've seen my video on impulse control disorders, you would know that I talked about how the chapters in clinical psychology are split into 3 sections, which are your diagnostic criteria, then the explanations, and finally you have your treatment and management. Now, the diagnostic criteria focuses on the guidelines that one must follow in order for an individual to be accurately diagnosed with a certain disorder. So we often refer to the International Classification of Diseases, the ICD, the 11th edition of it. So the ICD-11. You guys are probably familiar with the DSM, which was looked at in the button phobia study. And that's basically a manual with the criteria and symptoms for different psychological disorders. So I believe the current one that is being used is the DSM-5. So similar to that, we have another diagnostic tool or guideline, which is the ICD-11. And like I said, it stands for the International Classification of Diseases. So that is a very reliable and validated diagnostic tool that we can use to help us characterize different disorders, such as schizophrenia, and help us understand what are the symptoms, what are the different types of disorders that fall under a certain disorder, and how long, like what should be the duration in order for someone to be diagnosed with a disorder. So all of that is covered in this section of the diagnostic criteria. So let's see what we learned about schizophrenia in the diagnostic criteria. So it falls under the larger category of psychotic disorders. And psychotic disorders involve a major break from reality, where the individual tends to perceive the world in a very different way than how others would. So people who go through psychotic episodes under psychotic disorders, they tend to view the world in a very different manner. And you'll come across some symptoms that we'll be discussing, but you're probably familiar with terms such as delusions and hallucinations, right? Where people may hear or see things are that seem very real to them, but for others around them, they may not exist. So their perception of the world uh, in their mind is very different, and they may start seeing or hearing voices or seeing things which don't necessarily exist. So schizophrenia is a severe type of psychotic disorder, and ICD-11 characterizes schizophrenia by disturbances in an individual's thoughts, feelings, emotions, and behaviors. This is more of a general definition of what schizophrenia is according to the ICD-11. It says over here that the ICD-11 was developed by the World Health Organization, and it is a global standard for coding health information and includes both physical and mental health disorders. It's globally accepted, so it's a very validated and reliable tool. Okay, moving on. So according to the ICD-11, let's try to understand what are the symptoms of schizophrenia. Now, the schizophrenia symptoms fall under 2 main categories: positive symptoms and negative symptoms. Now, you would think that positive symptoms refer to good and negative refers to bad, but at the end of the day, it's a disorder. So, symptoms aren't really ever good, right? So, positive symptoms over here do not refer to good symptoms, okay? The word positive over here has a different meaning. They are essentially talking about experiences that are in addition to normal behavior or a distortion of normal behavior or experience. So think of positive as additional, extra behaviors. So more than the norm. So almost like saying abnormal behaviors. So unusual behaviors, extra behaviors which people tend to not normally display. Okay, for example, hallucinations, right? Let's take a look at 4 examples of your positive symptoms that one may experience with schizophrenia disorder. Persistent delusions. Now, delusions are a word that we tend to throw around in our everyday, the way we use it in everyday life. it's not very accurate the way we use it, because delusions, when someone is suffering from, let's say, delusional disorder, it's very different to the way we understand delusions. So delusions, we know, are false beliefs that people hold that are not really based on reality. And it's common for people even without schizophrenia to be delusional, experience certain delusions. But the key term here is persistent delusions. So what we'll see is in the whole of clinical psychology, not just in this chapter of schizophrenia, but there will be certain symptoms, certain behaviors that, while you're also going over it, you might think, you know what, this is something that applies to me. This is something that I go through. Does that mean that I have this disorder? Will not necessarily, because it's possible that individuals may experience symptoms or behaviors similar to these symptoms, but it's not for a prolonged period of time. It's only when some of these symptoms are persistent, extremely severe, and causing a major hindrance to your daily life, to your regular functioning, that's when it becomes perhaps a symptom of a disorder. So delusions are beliefs that people hold that are not based on reality. For example, thinking that someone wants to harm you, thinking that maybe someone is conspiring against you and is secretly plotting something against you and wants to hurt you or harm you. Now, that's not completely impossible, but if it's highly unlikely, for you to even think that way, but you still do, it's probably a delusion. And if that's something that you are persistently and constantly thinking about, it's a belief that you persistently have, then it categorizes as a persistent delusion. Now, delusions are beliefs. Hallucinations are more of sensory experiences where people see things or hear voices that don't exist. So, auditory hallucinations, visual hallucinations, people might see certain, um, you know, cartoon characters, or they might start hallucinating about angels or demons. People have given different examples of what they see. And a lot of people bring up the um, another side of this argument, which is that what if these are true? Because maybe it's they're trying to explain it from a spiritual or religious perspective, that maybe the individual is able to see these beings, and we're not able to see it. So that's a completely different way of looking at it. But from a psychological perspective, we are going to analyze it as saying that these do not exist, and they only exist in the mind of the patient with schizophrenia who's actually going through it, who's suffering from it. So you tend to view things, you tend to see things, you tend to hear voices that don't exist. All right. So, and people who, if you take certain drugs, um, it's possible that you may hallucinate. So just because you're hallucinating and you're seeing things or you're hearing voices, as a result of a certain drug that you've taken or side effects of a medication that you've taken, that doesn't mean you've got schizophrenia. Because the moment the effect of that drug wears off, your behavior goes back to normal. Which is why, again, it says persistent hallucinations. Because someone with schizophrenia would not need to take these drugs for them to be experiencing these hallucinations. It would occur more naturally and on a more consistent basis. So that would be persistent hallucinations. Then we have thought disorder. This is a third positive symptom. And as you can see, these are all behaviors that are more than normal, okay? Unusual, abnormal behaviors, an addition to the norm, okay? Distorted behaviors almost. So thought disorder is an inability to think, and as a result, speak in an organized manner. So basically, because you are unable to think clearly, you're unable to speak clearly. So your voice, well, not your voice, but your speech may seem very incoherent and very jumbled up. And at times, it will be very difficult for people to understand what you're trying to say because your thoughts are not organized. And obviously, if your thoughts aren't organized, our speech is based on our thoughts. So if our thoughts aren't organized, then when we speak our thoughts, then our speech might be very incoherent and difficult to understand for other people. So that's the third one. The fourth one is similar to the first one, experiences of influence, passivity, or control. This is a belief that one's thoughts or actions are influenced or controlled by someone or something external. So, for example, if you believe that aliens or the government are controlling you and your thoughts and your emotions, then this would be experiences of influence, passivity, or control. Okay, where you feel that you're going through an experience that someone is controlling you, controlling your mind, controlling your thoughts, controlling the way you behave, and so on. So these are all examples of positive symptoms. Let's take a look at negative symptoms now. Negative symptoms are symptoms where an individual um, may experience certain behaviors that are less than normal. Okay, so it's a level of functioning or experience that falls below normal levels, and there are four types that we can talk about over here. So positive symptoms are basically symptoms where you are experiencing additional behaviors. Negative symptoms are where you're experiencing behaviors that are less than normal. So behaviors that you would normally expect people to display, they're not even showing those. For example, avolition. This is a lack of motivation, and an individual with the disorder can experience this. So avolition, motivation is basically something that people can experience. Certain things can motivate you, but someone experiencing negative symptoms of schizophrenia, particularly avolition, may lack any real motivation to do anything. Along with that, very common negative symptom that people with schizophrenia display is flattened affect or flat affect. This is when you look at their expressions and their face almost has a very flat expression. They're not really displaying any visible emotion or expressions, for example, frowning, smiling, or any other type of expression. They've got a very blank expression on their face. Third type is impaired cognitive function. So people have a certain level of attention and memory, but when you have a reduced level of memory or attention, then that can be categorized as impaired cognitive function. Now, again, this doesn't mean that if you have poor memory and poor, very low attention span, you've got a negative symptom of schizophrenia. Uh, like again, I said, you have to meet the certain criteria that is mentioned in the ICD-11. So it's not that you just have to have one of these symptoms. It could be a combination of positive and negative symptoms, and it also depends on the severity and the duration. And lastly, catatonia. So catatonic behaviors or catatonia is a lack of movement or speech. So if you've ever met someone with schizophrenia, you would perhaps notice that they don't really have any, they're not very animated in their movement and their expressions. They're often in very still, rigid poses where they don't really move much, and you might not even see them speaking much at all. Perhaps even at times just, staring into space or just staying in one position, and, it's almost like a statue. So that's catatonia. So again, as you can see, these are all behaviors, regular normal behaviors that are lacking in these individuals. So these would be negative symptoms. And in order to be diagnosed with schizophrenia, symptoms must have persisted for at least a month. So when we say persistent hallucinations, persistent delusions, we are saying pretty much just at least a month. And again, it cannot be attributed to any other health condition, any other psychological disorder, substance abuse, or even side effects of medication. So if these symptoms are the result of side effects of medication, alcohol, drugs, or any other health condition, then it cannot be considered as schizophrenia. This is the diagnostic criteria. Um, let's take a look at an example study to help us understand a real life case of a child with schizophrenia. So this is a case study. It's an example study. Now, example studies are important as well. So if anyone tells you that just focus on the key studies and not example studies, that is a lie. Both are equally important, and you can be questioned on literally anything in a chapter. So you can't really leave anything out. So this is in 2018 by Anija, and it was on a boy who was 10 years old who started showing decline in his academic studies and general behavior. And it was around 2 years later, by the age of 12, where he really started showing some symptoms of schizophrenia. For example, auditory hallucinations, where he started to hear voices, and he believed that his mother, along with other people, could communicate with these voices. He would often scream and shout at these voices or at people who weren't there. He talked to himself a lot. He became quite erratic. His self-care declined, wouldn't be sleeping much. He was taken to hospital where he was treated with medication to try and control his symptoms from getting worse. And because he became really aggressive, he was eventually released from hospital through the medication. Sorry, he was released from hospital once his aggressive behaviors were kept in check through the medication. Okay. He was diagnosed with having early onset schizophrenia. Now, early onset disorders are disorders that occur in childhood. So you would think that most disorders occur in adulthood, but no, it's possible for children to also get some certain disorders and experience symptoms of certain disorders. And if children experience certain disorders, then we categorize that as early onset disorders. So this child was diagnosed with early onset schizophrenia. So some of his behaviors were kept in check with medication. However, he still suffered from some negative symptoms. And because of those negative symptoms, he displayed behaviors such as social withdrawal, apathy, and this would lead to him resisting wanting to go into school because obviously, it would be a little difficult for him, cause him psychological harm because, he's going through a lot of mental distress because of his condition. This was a very short and simple case study to help us understand a real life example of a child with schizophrenia. Now, we're still under the diagnostic criteria because we're still learning about different symptoms. And one of the symptoms was persistent delusions. So over here, we're talking about types of delusions, okay? Delusional disorder is a type of psychotic disorder as well, and delusions are part of schizophrenia. It's a symptom of schizophrenia, but you can have delusions in isolation. You can have delusional disorder where you only have delusions and you may not necessarily have the other symptoms of schizophrenia as well. But because delusions are part and they're one of the positive symptoms of schizophrenia, we are going to be discussing the different types of delusions that someone with schizophrenia could potentially experience. So delusions fall under two types, bizarre and non-bizarre. Bizarre delusions are those that are highly unlikely, almost impossible. Like perhaps believing that aliens abducted you and conducted experiments on you. So almost like impossible for them to occur. But you believe that it did. So that's a bizarre delusion. Okay. A non-bizarre delusion is one that is highly unlikely but still probable. For example, thinking that your partner is having an affair and cheating on you. Now, let's say, you don't really have any evidence or any reason to think that way. So that would be, a delusion, but it's still something that is not completely unrealistic. So that would be categorized as a non-bizarre delusion. So there are three types of delusions that are in your syllabus. Persecutory delusions are perhaps the most common that people with schizophrenia experience. This is a delusion where an individual believes that others are conspiring against them and are pursuing them to cause them harm. So if you ever met someone with schizophrenia, you might notice this erratic behavior of theirs, where they feel that there's someone who wants to harm them or some people who want to harm them. They can become very paranoid as well. And I actually know someone who wasn't taking their medication, and then they started becoming very hostile and aggressive. So their family had to call the doctors to come and take them to the hospital to kind of control their behaviors and almost force them the medication. So this individual, when they saw the doctors come, they thought that these doctors are here from, some people from the government who've come to take her away and do experiments on her. So she thought that they were conspiring against her and they wanted to harm her. So she kind of locked herself up in the room, and then when they came up to kind of get her out, she went to the balcony, and I think she was also like trying to jump over the roof or something. So just to try to escape them. So, that's definitely a persecutory delusion that she was experiencing. So these are perhaps the most common delusions that people with schizophrenia experience. Because they become so paranoid, their behaviors can become erratic and aggressive, and at times it can even make them very dangerous to others around them. Grandiose delusion is another type where people believe that they have some special ability or special power. For example, there's some superhero, or they have some very special status or purpose in life, like they're the savior of mankind or something, right? So at times they might think that right now I'm living a normal life, but I am destined for greatness. Now, obviously, people can think that way, and you can use that to motivate you to achieve great things in life. But if you genuinely believe that you've been put on this earth for this particular purpose to save mankind, and you are humanity's savior, and you've got some special skill, special power which only you have, that's probably a grandiose delusion. Delusions of reference is a belief that some experiences in the environment, such as a TV program, is talking about you. Okay, you're part of some event, watching a TV show, and you think it's based on you and they're talking about you. So that's delusions of reference. Now, there are other types of delusions as well. These two were part of the previous syllabus, so I'll still cover them even though they're no longer there in your textbook. But it's good to know a few more just in case. Erotomanic and jealousy delusions. Erotomanic delusions are delusions where you believe that someone is in love with you. Again, it's possible, but if it's, let's say, someone you haven't even ever met. Like, for example, you think you've never met Cristiano Ronaldo, but you think that he's absolutely in love with you. So, that's obviously a delusion. It's an erotomanic delusion. Jealousy delusion, a belief that one's partner is cheating on them. Again, this is more of a non-bizarre delusion. Yes, if there are reasons for you to think that way, fair enough. But if there's absolutely no reason for you to think this and you still are believing it, then it's probably more of a delusion. And similar to schizophrenia, for someone to be diagnosed with delusional disorder, you must experience these symptoms for at least a month or longer, and it should not be attributed to substance abuse or explained by any other psychological or mental disorders. Now, every chapter in clinical psychology has one key study. And although key studies are important, it doesn't mean you focus only on these and you ignore the example studies. But key studies are a little more detailed. Key studies are definitely going to be included in paper 4. There is no guarantee that they will come in paper 3. Sometimes your 6-mark describe and 10-mark evaluation can be just on the entire key study. And at other times it could be on 2 or 3 example studies. So, make sure you've covered everything and don't leave any one particular topic out. So let's take a look at the key study. The key study for this chapter falls in the diagnostic criteria. And with this, we can conclude the diagnostic criteria for schizophrenia. And the name of the key study is Symptom Assessment Using Virtual Reality by Freeman in 2003. So if any of you ever do any research on the Freeman study, let's say you decide to, go online and get some more information about the study for the purpose of your studying and your, maybe you want to get some extra information about the study for your exam, you might come across another study by Freeman, which was conducted in 2008. And that was similar to this, but it was a different study, as because it was on different participants. The setup was different. And that was actually a study that was part of the previous syllabus. This time they're giving the 2003 study as opposed to the 2008 one. So if you do come across another VR study by Freeman, please don't get confused. Don't mix up the two. So what is VR, virtual reality? You guys your age should be familiar with this. A lot of people, nowadays you have these games that are based on VR where you put on this headgear and there is the screen, and you can have some controls or gloves, so you're completely immersed in this computer simulation in this fake environment. And the characters or animations that are in this environment are referred to as avatars, and you may interact with them. If you're playing a game, it seems very real to you. So VR is used obviously for the purpose of games and leisure, but it can also be used for other purposes, psychological purposes as well. For example, VR has been used for helping people with, focusing on their public speaking, improving the public speaking, people with social anxiety who get a little nervous and anxious around people in their daily lives. They can perhaps train to become a little more confident around a lot of people by putting on this VR headgear and being around a bunch of avatars. So they know the environment isn't real, but by doing so, they can kind of condition themselves to be a little more comfortable around a group of people without actually having to be around a group of people. And once they're a little more comfortable in the VR setup, then perhaps they can go to the real world and then see if they feel an improvement in their social anxiety or not. So yes, it's used for many purposes. It can also be used to help people with psychological disorders such as treating phobias. Okay, for example, social anxiety. Some people have agoraphobia, which is a phobia of being in public spaces. So in this study, Freeman is using virtual reality to assess symptoms of persecutory ideation, which is pretty much the same as persecutory delusions. We just talked about persecutory delusions. So persecutory ideations is the idea that you think someone wants to harm you, is conspiring against you. So we want to see if we can use virtual reality to assess for symptoms of persecutory ideation or persecutory delusions. So in the real world, if you have persecutory delusions, it can be a little difficult to determine if these are real or not. If you think someone is conspiring against you, someone wants to harm you, someone is judging you, someone is laughing at you, it's difficult for us to ascertain if that is a delusion or if that is really the case. Because in the real world, there are a lot of variables that you cannot control. But in a VR setup, the entire setup is artificial. So if you're interacting with these animated avatars and you think that they want to harm you or they want to hurt you and they're judging you or laughing at you, and you genuinely believe that, then we know that that is definitely a persecutory delusion because it's not even a real setting and they're not real people. So, this could be a good way to help us understand if someone might be experiencing persecutory ideation, which is why this is called symptom assessment using VR, using virtual reality as a tool to assess for symptoms such as persecutory ideation in people, because therapy can be a little difficult to try and really say for sure if the symptoms that or the delusions are describing are real or not. So VR is perhaps giving us a deeper insight into an individual's possible delusions. Now, the catch here is that the sample of the study isn't on people with schizophrenia. It's actually done on a non-clinical group. A non-clinical group means a group of people without any mental or psychological disorders or mental illnesses. So the sample of Freeman's study are actually people without any mental illness. They don't have schizophrenia. And I told you earlier, it's possible for people even without a disorder to have delusions, to have persecuted delusions, because you can be paranoid about things. But again, it doesn't mean that you have delusional disorder, because we talked about the diagnostic criteria. It should be there for at least like a month, and it should be persistent. But it is possible that people without the disorder can experience these delusions as well. So you can be paranoid, you can experience certain delusions, even though they don't necessarily have to be persistent. But non-clinical people and people without disorders, they can have ideas of persecution. That's why it's called persecutory ideation. You have certain ideas or thoughts of paranoia in certain situations, right? It's common. You might be in a certain situation where there are people around you, you hear them laughing, and you think that they're laughing at you, you think they're judging you, which in reality might not be the case. It's human nature. So that's because paranoia is associated with persecutory ideation, persecutory delusions. So rather than really calling it a delusion, that's why instead we're referring it to as persecutory ideation. Okay, ideas of persecutory thoughts or paranoid thoughts. So that's something that people without any disorder can experience as well. And we want to see if we can assess those symptoms, assess these behaviors, assess these ideations while using VR. So the sample of the study will actually be tested in a VR setup where they'll be interacting with these avatars, these animated characters, in a simulation, and we want to assess if we can pick up any persecutory ideations that these participants may display. So the sample is not a very large one, it's just 24 individuals, 12 male, 12 female, 21 of whom are actually students from University College London in the UK, and 3 of them are admin staff, making up the average age of 26 years. Not a very generalizable sample. None of the participants had any mental illness, so you cannot generalize it to people with mental illnesses. You cannot generalize it to a larger group of people outside this university, people outside UK. So, cultural differences must be taken into consideration. They're all of a certain age range as well. So generalizability would be a weakness of this study. And they were recruited through a volunteer sample where they responded to an ad. This is important for paper 4 research methods. What's the procedure now? Now, I've said it's a lab experiment, but to be fair, it's more of a correlational study with the use of self-report. Um, Treat it like a controlled setup, which is why I've called it a lab experiment, but it's not really an experiment because technically there isn't an IVDV, but there are many controls. It's better to refer to this as a correlational study with the use of a lot of self-report. The participants were initially trained on how to use the VR, and the setup that they would be in would be a library scene. So the simulation was of a library. They would each view the simulation for 5 minutes. So that's a control. And it would involve 5 avatars, 3 of them sitting on a certain desk and 2 of them sitting on another desk, displaying different types of behaviors such as smiling, looking at the participant, talking, and so on. The participants weren't really told that their persecutory ideation was being tested because you want to avoid demand characteristics. Instead, they were told that they have to interact or be immersed in this VR setup for around 5 minutes in this library setup, and they have to form an impression on what they think, or basically form an impression on these avatars and give their opinions on what they think the avatars are thinking about them. So if you are a participant, I'm going to tell you to put this headgear on. You'll be in this library setup, the simulation. You'll see these avatars. I'm going to ask you to tell me what you think these avatars are thinking about you. Okay? And these questions, some of them will be positive, some of them will be negative. Just to get an idea, if you have like negative ideas about these avatars, do you think that they are looking at you or judging you in a negative way? So are you developing negative opinions about them or positive opinions about them? So that's basically what the participants are being told. And that is something we do want to assess, but for the purpose of testing for persecutory ideation. So that purpose was not set to the participants. Now, how are we going to collect data? So you would think that, if they're in a VR, we could observe them and we could see if they're showing any persecutory ideation, but it's difficult to observe that because persecutory ideations are thoughts and beliefs. You can't observe someone's thoughts. So even if they are in this 5-minute setup and people are feeling, or going through experiences of persecutory ideation, where they think the avatars are maybe looking at them, judging them, um, talking about them behind their backs, that's something that we might not be able to very easily observe. So observation wouldn't be the best technique to collect data. Instead, self-report would make more sense, where we can actually ask the participants what they think. What do you think is going on? How do you feel? So that's why we told them that they have to form an impression about the avatars and let us know their opinions about what they think the avatars are going through and thinking. Now, one of the ways in which we can collect this information is through questionnaires, and the other is through interviews. So basically, self-report. And a lot of questionnaires are actually being used to collect data. So it's a relatively holistic approach to collecting information about your symptoms. One of the more important questionnaires being used is the brief symptom inventory. You can just remember this as the BSI if you want. You don't need to know the full form. This is a 53-item self-report questionnaire, which means the participants have to rate themselves. And I think it's on a scale of 1 to 4. And it's assessing 9 different symptom dimensions over the past 1 week. So what this questionnaire is doing, if you see the term brief symptom inventory, so it's getting an idea about different types of symptoms that you may be experiencing. What type of symptoms? 9 different types, which include things like depression, anxiety, interpersonal sensitivity, which is a feeling of discomfort or inferiority when you're interacting with people. So, sometimes people, they interact with others and they feel a sense of inferiority, almost like an inferiority complex when talking to others. That's interpersonal sensitivity. So we've got 9 such symptoms, and there'll be some items on interpersonal sensitivity, some on depression, some on anxiety, some on hostility, and so on. This makes up a total of 53 items, and you have to rate whichever of these symptoms, whichever of these items for each of these respective 9 symptoms apply to you, or you feel relate to you, or at least have related to you within the past 1 week. Okay. The reason why you want to get information on these symptoms is because it's a correlational study. We want to see if there is a correlation between any of these symptoms and persecutory ideation. So, for example, if you're a very anxious person, are you also someone who's likely to experience more persecutory ideation? Which would make sense because persecutory ideation is, where you kind of feel a little paranoid because you think people are talking about you, they want to harm you, they want to hurt you. And if you think that way, then it's common for you to maybe feel anxious. So that's why we're taking a look at these other symptoms and seeing if there's any correlation between these symptoms and persecutory ideation. So you will let us know if you're experiencing persecutory ideation through certain questions that will be asked of you on the VR experience, on the VR simulation, and then we'll get an idea about any other symptoms through these questionnaires, and then we'll see if there is a link or not. Okay. Other questionnaires are just a general anxiety questionnaire, a paranoia questionnaire, um, a sense of presence to see how much you felt that you were actually a part of that VR setup. Or did you feel like it was very fake? And because if you think it's not very real and you are not very immersed in it,
then you might just be giving demand characteristics. So if you're genuinely very involved and immersed in it and it feels very real to you, then your responses will be a little more genuine. And also specific ideations of persecution. So people can have different persecutory ideations. Some might think that, they want to harm me. Others might think that they're making fun of me. So it's different types of persecutory ideations. We're asking them questions on that as well. There was also a semi-structured interview that was conducted where, we asked them questions about their anxiety, about their paranoia, and so on. The questionnaires are mostly close-ended on the rating scale from 1 to 4. Now, half of the participants, with an equal number of males and females, actually took the questionnaire once before going through the VR setup and then once again after the VR setup. And the other half took it only after the VR simulation. Now, why are half the participants taking it before and after and the other half only after? Again, I guess you could say for demand characteristics to be tested, because if there is a difference in the scores between those who are taking the questionnaire only once after the simulation and those who are taking it twice, once before and one after, then maybe that is suggesting some sort of confounding variable. Because what if you're rating yourselves as being very paranoid or very anxious, or maybe not at all paranoid or not anxious? You go through the VR setup and then your ratings change after you take the questionnaire again. So that's somewhat of a comparison that we're trying to make, which is why half the participants are taking the questionnaire twice, once before and once after, and the other half are taking it only after the task. What are the results? There was a significant correlation between the scores on the paranoia questionnaire and the paranoia score in the interview. So while interviewing you, if you're rating you as being someone high in paranoia, for those of you who don't know, is basically when you are a little suspicious of people, and that causes you to be be very worried and thinking that people want to hurt you, or it's kind of like persecutory ideations. So paranoia is very closely linked to that. So those who actually rated themselves high on paranoia, they also had a high score during the interview when the interviewer was trying to assess for your paranoia scores. Majority of the people had positive opinions of the avatars, but some did show ideas of persecution. For example, one of the items that was given to the participants in the questionnaire was to rate if they thought that the avatars were talking about them behind their backs. So the item, they were talking about me behind my back, 11 of the 24 did not agree with this. So 11 are, not really suggesting ideas of persecution. 8 slightly agreed, 3 moderately agreed, 2 totally agreed. So there were 2 people who definitely experienced persecutory ideation, and another 3 who potentially did, and 8 who kind of slightly did. So there are some people, with certain ideas of persecution, some more so than others. So, individual differences. But there were no differences in the scores or significant differences in the scores of males or females, or even those who took the questionnaire twice compared to those who took it. Okay, persecutory thoughts about avatars and paranoia scores do not have any significant correlation. An important point is the second one. Those who actually had higher interpersonal sensitivity and higher anxiety were also the ones who had high levels of persecutory ideation in the VR. So we're seeing 2 very strong positive correlations. Anxiety levels and interpersonal sensitivity levels were very positively correlated with higher levels of persecutory thoughts. So the more anxious, the more interpersonal sensitivity that you have, the more you're likely to experience persecutory ideations, at least in this VR setup. Okay. So the results conclude that people do attribute mental states to VR characters, and they are usually positive, but they can also be persecutory in nature. And those with more levels or higher levels of interpersonal sensitivity or anxiety are also people who are more likely to experience these persecutory ideations. So that is the study. We could maybe quickly evaluate it. So I talked about the generalizability being low. Sticking to some weaknesses, maybe ethics, because they volunteered. So yes, it's there is consent, but they weren't really told about the real aim that they were testing for persecutory ideations. You can kind of argue that consent wasn't provided for the true purpose of the study. And potential psychological harm, particularly those participants who did experience persecutory ideation and thought the avatars were maybe for example, talking about them behind their backs. So a little bit of ethical issues here. reliability is a strength, very standardized procedure. Everyone went through the same 5 minute simulation with the same avatars, given the same rating scales to rate on. So standardized procedure, easily replicable for reliability. Validity is also high because it was a very holistic approach. So it's not reductionist if you talk about the issues and debates, because we're using multiple techniques to gather data, multiple questionnaires, interviews, quantitative, qualitative data. So, looking at different symptoms and the link between different symptoms with persecutory ideation. So it's a relatively holistic approach. Um, what else can we say? In terms of the individual situational debate, I would say it's individual because everyone was in the same VR situation of a library, but there was a big difference in persecutory ideation. So 11 did not have any, 8 slightly, 3 moderate, and 2 total. So these differences in scores are attributed to individual characteristics. Okay, some were more anxious than others. Some had higher interpersonal sensitivity than others. All of these individual traits are the reasons for why some people had higher persecutory ideations than others, or why some did not have any at all. So these are all individual points. So the individual explanation is being favored rather than the situational over here. The application of the study is quite high because we can now use VR to assess symptoms of persecutory ideation in a valid manner, because in the real world, it might be a little more difficult to determine if the delusions are real or not. But in the VR setup, we do know because it's an artificial setup. So any persecutory ideation or any thoughts, we know are genuine thoughts, and they're not actually a case where the avatar does want to harm you, because we know it's not real setup. But so that can be helpful in diagnosing or assessing symptoms at least of persecutory ideation. But the issue is that, one, it's not generalizable, so that can lower the application because it's not applicable to other a larger group of people of different ages. What about those who are older who don't really know how to use virtual reality? They might be really uncomfortable. What about people of other cultures who you know don't are not really accustomed to using VR? So for them, just the idea of being in a simulation can cause them a certain sense of paranoia in certain cultures. So we must take into account cultural differences as well. Um, Ecological validity is also low because obviously, just because they're showing persecutory ideation in a VR, it does not necessarily mean that this will be the same behavior that people may display in the real world, right? Because what is done in a simulation in an artificial setting cannot very easily be applied to real world experiences. So ecological validity would be a weakness as well. And we can end with one last issue and debate of the nomothetic idiographic debate. Idiographic refers to case studies, qualitative data, one individual. This is not a case study. This is done on a group of people, and it's getting a lot of quantitative data through close-ended questionnaires and self-reports. So this is favoring the nomothetic side of the debate. On that note, we can move on to the second topic, which is the explanations, which focuses on the cause of the disorder. And explanations in all 5 chapters, all 5 disorders are typically split into biological explanations and psychological explanations. So let's take a look at the biological explanations of schizophrenia. And within the biological explanations, we have 2. The first one being the genetic explanation. Now, over here, we're looking at the role of obviously genes, and the 3 types of studies that we'll be looking at to see if there is any genetic link for schizophrenia. One is family studies, which is the idea that, if someone, a close family member, has schizophrenia, does that increase your chance of potentially developing the disorder? More so than, it being developed generally, because in the general population, your chances of developing schizophrenia are 1%. But does that shoot up if you have a close family member with the disorder? So those are family studies. Then we have 2 twin studies. So we want to see what is the likelihood that if one twin has schizophrenia, the other is perhaps going to develop symptoms as well. And over here, we'll compare identical to non-identical twins as well. And thirdly, adoption studies. So let's take a look at what the genetic explanation says. Start with family studies. So family studies are studies conducted to investigate whether biological relatives of those with a disorder are more likely than non-biological relatives to be similarly affected. Um, there's not much of a detailed study here, but it says that a general trend has been shown, um, where people with close family members who have the disorder are also more at risk of developing symptoms of the disorder. And yeah, so family studies, again, there's not much information here, but what we do know is that if you have a close family member with the disorder, your chances of developing the disorder increase compared to the general populations. For twin studies, there is very important study by Gottsman in 1991, Gottsman and Shields. And Gottsman noted that the likelihood of developing schizophrenia is 1% in the general population, but this increases to almost 50% if you have an identical twin with schizophrenia. So this was tested through a study that he did on 57 pairs of twins, which he actually got from a larger group of 467 twins at the Maudsley Hospital in London between 1948 and 1964. So 57 pairs of twins. And the twins that he got for his study were either monozygotic or dizygotic twins. Now, monozygotic or dizygotic, you don't have to know the full form. You can refer to them as MZ for monozygotic or DZ for dizygotic. Monozygotic twins are identical twins, twins that share 100% of their DNA, completely identical. And dizygotic are those that share 50% of their DNA and are non identical twins. And how did we find out whether the participants from the 57, how many were identical, how many were non-identical? Well, you would think obviously by looking at them, we'd be able to tell. But for a more valid conclusion, DNA testing was done to ascertain which of these twins were um, MZ and which were DZ. Now, what is Gottsman looking for between these MZ and DZ twins? He's looking for something called concordance. Concordance is the likelihood of one twin developing a certain trait and the co-twin also possessing that trait. So concordance over here is the likelihood that if one twin has schizophrenic symptoms, what's the likelihood that the other is going to potentially also develop the disorder? Okay, so from the 57, 24 were MZ twins and 33 were DZ, MZ being identical, DZ being non-identical. Now, you obviously would, you know, be able to figure out that MZ twins who share 100% of their DNA, there's a greater chance or a greater concordance of schizophrenia for MZ twins than DZ twins because they share more of their DNA. Results actually showed a 50% concordance rate among MZ twins, whereas for the DZ twins, there was only a 9% concordance rate, suggesting a genetic link. So if you are an identical twin and your co-twin has schizophrenia, your chances of developing schizophrenia shoot up by 50%. Whereas if your co-twin who is non-identical to you, you are DZ twins, and your co-twin has schizophrenia, then your chances are only 9%. So this was one twin study. Is it generalizable? Not at all. It's not even done on regular siblings, it's only specifically twins. So that's a bit of an issue with this study in terms of its generalizability. Hilker is the other twin study. This is on a more large scale. Okay, 30,000 twin pairs in Denmark. How did he get so many twins? He got the information through two national registers, the Danish Twin Register and the Danish Psychiatric Central Register. And when analyzing those who had schizophrenia, he found a 79% heritability rate. So for those twins who did have schizophrenia, they found that there was a 79% heritability or genetic link, which means that their co-twin was also likely to also have the disorder. So a 79% genetic link, okay, of them both developing the trait of schizophrenia. And lastly, adoption studies. This looks at the similarities between adopted individuals and their biological parents. So we want to compare children who have schizophrenia, um, those who have a biological mother with schizophrenia to those who do not, who have a biological mother without schizophrenia. So the children in this study who we're studying are all, who TNRE in 2000 is studying, are all, well, most of them are children with schizophrenia, and we're comparing those with a biological mother who has schizophrenia to those who have a biological mother without schizophrenia. And there was 6.7% children with schizophrenia who also had a biological mother with schizophrenia, compared to only 4% of children who had a biological mother without schizophrenia. So although they were adopted,
there was a higher chance of children developing schizophrenia if their biological mother also had it, as opposed to if their biological mother did not have it. What's the purpose of this study? They're adopted. Maybe their schizophrenia could have been environmental. That's what you want to see. Are those whose biological mothers who don't have schizophrenia, are those the kids who are more likely to develop disorder, or the ones whose biological mother does have schizophrenia? And the ones whose biological mother did have schizophrenia, more of those kids also developed the disorder compared to those whose biological mother did not. 6.7% compared to 4%, suggesting it is more genetic than it could be environmental. Now, this was the genetic explanation, the three topics. In terms of the nature-nurture debate, it's definitely nature because it's trying to explain the onset of schizophrenia through biological factors, okay, genetic. It's reductionist, however, because we're ignoring other factors. We're ignoring biochemical factors, the role of certain chemicals in the brain. We are ignoring psychological or environmental factors, which could perhaps explain the onset of the disorder. And even within the role of genetics, it's focusing on, for example, Gottsman is focusing only on twins. What about regular siblings, right? So it's very reductionist. It's deterministic because if you have a co-twin and you're identical, then your co-twin has schizophrenia, then your chances shoot up by 50%. That's not something you can do really anything about. It's not your free will. So it is deterministic. It's also nomothetic because we're kind of establishing this law that if you're an MZ twin, then your concordance rate shoots up compared to a DZ twin, right? So um, it's like a law that you're establishing about human behavior, that genetics does play a role in the onset of schizophrenia. Um, so yeah, these are just some evaluative points. Let's move on to the second biological explanation. This is the biochemical explanation, also referred to as the dopamine hypothesis. Dopamine is a neurotransmitter. It's a chemical in the brain. Now, to understand the role of dopamine, we have to understand how the brain works. Your brain has billions of neurons or cells. If you remember, we talked about this in the AS level study on mindfulness by Holzel. We understood how the brain works. You've got cells or neurons in your brain, okay? And you know that signals are constantly being sent and received in your brain, right? Messages are being sent and received. That's how you understand information. That's how you process information. That's how you respond to information around you through these messages and signals being sent in your brain. So these messages and signals are being sent from one neuron to the other. And these neurons are in different areas of the brain. So certain messages will be sent to, for example, neurons in the Broca's region, which is a part of the brain that is responsible for formation of language, which allows you to speak, allows you to talk, allows you to speak in a certain language. It's all because of messages being sent and received. Now, how are these messages being transmitted from one neuron to the other? Through neurotransmitters. Okay, these are chemicals that carry signals and messages from one neuron to the other. One example of this chemical or these chemicals or neurotransmitters which carry signals is dopamine. Dopamine is a chemical or a neurotransmitter in your brain that carries messages from one part of the brain to the other. And dopamine is referred to as a happy chemical. When you get your grade and you get an A grade, you feel excitement, you feel good, you feel, happiness. That's because there has been an increase of dopamine in your striatum, which would be the reward center of your brain. So that particular part of the brain, which is responsible for you feeling a sense of reward and excitement, that would be receiving a boost of dopamine. And dopamine is carrying the message of happiness, right? So that's basically what dopamine does. That's how it works. The dopamine hypothesis states that people with schizophrenia actually have unusually and abnormally high levels of dopamine. So dopamine increasing in the brain is not a bad thing. You feel happy, you feel good, and then it goes back to normal because people have got an enzyme in their brain that kind of breaks down the dopamine, allowing it to not be too high and being in a regulated and normal amount. Because once dopamine is in an unusually and abnormally high level in the brain, it can cause problems. It can cause you to now behave abnormally. So the idea is that high levels of dopamine can lead to positive symptoms of schizophrenia. Okay, so it does not necessarily mean that you're only going to be very happy.
too much dopamine for a long period of time can cause your brain to malfunction a little, where you start experiencing positive symptoms such as hallucinations and delusions. So, under the biochemical explanation, we're going to be looking at multiple pieces of evidence, not just one study, but multiple small studies or pieces of evidence to kind of understand the role of dopamine in the onset of schizophrenia. So, let's take a look at what it says. It is believed that certain parts of the brain, when they receive excessive or high amounts of dopamine, such as the Broca's region, which is an area responsible for the formation of language, it can affect and impair the individual's speech, which is a symptom of schizophrenia. So, thought disorder, which leads to you speaking in an incoherent and illogical manner, one reason for that could be explained by high levels of dopamine being produced in the Broca's region, because that's the area responsible for formation of language. So if there is excessive dopamine in that region, it would allow you to not be able to think properly, not allow you to therefore speak properly either. So one of the positive symptoms can be explained this way. And you're probably wondering, why is the brain producing high levels of dopamine? Okay, it's something that occurs naturally. It's not something that the individual is choosing to do themselves. Can you choose to increase your own dopamine levels? Absolutely. How? You can take drugs, you can take certain medications whose side effects would be that you increase dopamine, but then that's not schizophrenia, because that's something that's, you're doing yourself. But when the brain naturally has higher levels of dopamine receptors and the brain is naturally producing more dopamine, then obviously it's deterministic, and that's likely to cause positive symptoms. Let's take a look at another example of how dopamine could lead to schizophrenia symptoms. Drug trials are conducted on people with and without schizophrenia, drugs such as amphetamines, cocaine, and we've seen that these drugs can actually lead to symptoms such as hallucinations and delusions. Because, if people take drugs, they take alcohol, sometimes they hallucinate, they start becoming deluded because these drugs increase the level of dopamine in their brain. That does not necessarily mean they have schizophrenia, but it's just evidence showing you that dopamine can lead to symptoms that we experience in schizophrenia, such as delusions and hallucinations. Now, Parkinson's disease is a disease where people have. It's basically, I have a relative with this disorder. Muhammad Ali, the famous boxer, had Parkinson's in his later stages of his life. You will see that they have difficulty to maintain their motor ability, so they start moving in a way that they can't really control the movement of their body. They might start shaking a lot or squirming a lot. So one way to treat that is by giving a synthetic dopamine drug. So rather than, if the dopamine levels aren't increasing naturally in the brain, we can give you a drug that would artificially increase the dopamine through a synthetic drug called L-Dopa. Although this has been useful in treating or reducing symptoms of Parkinson's, it has certain side effects. For example, people who've taken this drug with Parkinson's have reported some positive symptoms of schizophrenia as side effects, such as hallucinations, right? Another piece of evidence, post-mortem studies, autopsies um, of people with schizophrenia. So we went through brain scans of these autopsies, and we found that these people, when they were alive, their brains had actually been producing higher levels of dopamine than a regular person's brain. I told you that there is a certain enzyme that helps break down dopamine. Wise found that people with schizophrenia have low levels of this enzyme. That is one reason why the dopamine is actually being produced in high levels, because this enzyme is in lower levels in their brain, so not allowing the dopamine to be regulated in normal amounts. So this could be one reason as to why the dopamine is in higher amounts than regular. PET scans, brain scans of people with schizophrenia compared to those without schizophrenia showed that there were the scans actually showed higher levels of dopamine in certain areas of the brain with people with schizophrenia compared to those without, right? For example, areas such as the limbic system, the striatum, and the cortex. If you can remember these areas of the brain, that will be great. So far, we've talked about positive symptoms, but what about negative symptoms? Does dopamine have any role to play in negative symptoms? Nestler in 1997 actually found that certain other areas of the brain, if they go through lower levels of dopamine, such as the prefrontal cortex, it can actually lead to negative symptoms. So high levels of dopamine in areas of the brain could lead to positive symptoms, but in other areas, such as the prefrontal cortex, if there are lower levels of dopamine than normal, you can actually experience negative symptoms such as flat affect. So if one area of the brain has got high levels of dopamine, it might be leading to positive symptoms. But if another area is going through unusually low levels of dopamine, then it might lead to negative symptoms such as flat affect. So clearly, all of these different examples are showing you that dopamine has a role to play in the onset of positive and negative symptoms of schizophrenia. So the biochemical explanation or the dopamine hypothesis is it reductionist? Is it holistic? Well, there are multiple pieces of evidences to show that it is important. So I guess the different evidence is holistic, but the end of the day, all of them are focused on just one explanation, which is that of dopamine. It's not taking into account the role of genetics. It's not taking into account the role of environmental factors. So I guess you could conclude that this dopamine hypothesis is reductionist. It is also deterministic because we're clearly focusing on the role of nature, and no one chooses to have high or low levels of dopamine. It's something that occurs naturally. So free will is not being favored over here either. And it's also nomothetic because it's not a case study. It's almost like a law that we're establishing that if your brain is naturally producing high levels of dopamine, you will experience positive symptoms of schizophrenia. Right? It's like a rule almost that is being established. So that's also nomothetic. Um, Cultural differences, not really, because it's biological. It's not looking at the nurture side, it's looking at the nature side. So cultural differences wouldn't really apply because it's nomothetic. And the last explanation is the psychological explanation. And under the psychological explanation, we have the cognitive explanation by Frith in 1992. Now, Frith is acknowledging the role of biological factors. He's saying, yes, I agree that schizophrenia could have a genetic link. I understand that dopamine has an important role to play, but it wouldn't be fair to say that these are the only factors. So he's taking a more holistic approach. He's actually trying to understand schizophrenia from a cognitive or a psychological perspective, that there is a problem in your thinking, your thought process, illogical or irrational thinking that is causing you to experience these symptoms. So let's see what he says. He believes that schizophrenia is abnormality of self-monitoring, which means all of us have thoughts in our head. All of us think to ourselves. Sometimes we think, out loud. Sometimes we have very strong, positive, intense thoughts. Some of us have minor, simpler thoughts. But at the end of the day, we know that these thoughts are internal. We know that these thoughts are our own, coming from our own mind, and we are, in somewhat control of them. People with schizophrenia, however, are unable to perceive this. They believe, according to Frith, that these thoughts that are coming from their own mind are actually voices from an external source. So they are struggling to identify their own thoughts as theirs, coming from their mind. And instead, they think that they are voices that they are hearing coming from an external source rather than internal thoughts from their own mind. So he refers to it as abnormality of self monitoring because they're unable to monitor their own thoughts. And they think it's coming from an external source, which could explain auditory hallucinations. So this misinterpretation of perception, this misperception, this misinterpretation of their thoughts, causing them to think that this is external rather than internal, could be the reason. So he tests this theory out. How does he test it out? On patients with schizophrenia, items are read out, and the patients are asked if these items were read out by the patients themselves, by an experimenter, or by a computer. And those schizophrenia patients who actually had incoherent speech and thought disorder as their major symptoms were the ones who struggled the most. So, suggesting that if these people are unable to identify if actual words that are being read out, actual voices that they can hear that are being read out, they're unable to identify where these voices are coming from, who is reading it out, then obviously they will struggle to identify where their own internal thoughts are coming from. So it makes sense that this is possible, that they think that their own inner thoughts are coming from an external source. Because when they're hearing actual voices, when they are hearing someone speak something or read something out to them, they're unable to figure out where these voices are coming from from themselves, from a computer, from someone else. So this abnormality of monitoring, this abnormality
monitoring is basically the reason why they are unable to um, acknowledge that these thoughts of theirs are internal and they attribute it to external thoughts. So that could explain certain positive symptoms. But for negative symptoms, um, Frith is saying that low levels of theory of mind could be the result of negative symptoms. Theory of mind, if you remember from Baron Cohen, is your ability to judge other people's emotions, think of things from other people's perspectives and point of view. Now, people with schizophrenia who might have low theory of mind, they're unable to perceive things from another person's perspective. And because of that, they're unable to interact with them, engage with them socially, they're unable to show any real levels of empathy. And as a result of that, it is common for them to not show any real expression or emotion, and hence show negative symptoms such as flat affect. So, through these cognitive elements, Frith is trying to explain the onset of schizophrenia. So, that's the cognitive explanation of schizophrenia. And if you were to evaluate this, we would say that it is a little more holistic than the biological explanations. And rather than reductionism, it's looking at a few more factors. And rather than it being deterministic, it is also free will, because you could say it's a little deterministic because they're not choosing to think this way. It's a thought that's coming naturally to them, but they have that choice to change the way they want to think. So there is room for free will. Through therapy, perhaps they could alter their thoughts, and they could realize that these thoughts are internal rather than external. So it's not entirely deterministic, it's not hard determinism, it is soft determinism, which is the idea that maybe the cause is perhaps something that is not within your control, but it does not have to permanently be like that. There is room for change, there is the element of free will present over here. And lastly, we have the treatment and management. Okay? The treatment and management of schizophrenia can also be broken up into biological and psychological. And in any chapter, it's usually like that. Because if you have a biological explanation for a disorder, it only makes sense to treat it biologically. If dopamine is at high levels of the brain which is causing the disorder, then the biological treatment would be focusing on reducing that dopamine level. If the cause is psychological, then the treatment would be psychological as well. If there are issues in your thoughts, then the treatment would be focusing on rectifying or fixing those thoughts and making them more rational. So the treatment and management of schizophrenia would be biological, which includes two types. Biochemical treatments, which would be the use of drugs, mainly typical and atypical antipsychotics. And the second biological treatment would be ECT, electroconvulsive therapy. And then we have one single psychological or cognitive treatment, which would be cognitive behavioral therapy, which is just regular therapy, talking therapy with a therapist. So, talking about the biochemical treatment, we've got antipsychotic drugs, typical and atypical. Now, the purpose of these drugs would be, if you take a look at the biochemical explanation, it was that there are high levels of dopamine, or there is high levels of dopamine in the brain that is resulting in schizophrenia symptoms, positive symptoms mainly. So if the dopamine levels are high, then the purpose of these drugs would be to counter the high levels of dopamine and reduce the dopamine. Schizophrenia is a psychotic disorder, so the antipsychotic drugs would be drugs to kind of reduce the symptoms. That's where the name comes from. And we've got typical and atypical because these are drugs that were developed in different eras. Typical antipsychotic drugs were developed much earlier in the 1950s, and then newer versions, more advanced versions with fewer side effects were developed in 1990s. So the first generation ones, or the 1990s ones, sorry, the 1950s, the typical ones in 1950s were referred to as first generation antipsychotics, and the 1990s atypical ones were referred to as second generation antipsychotics. Now, how do they work? So they work by reducing the positive symptoms of schizophrenia. And what they do is they block the dopamine receptors. So they don't allow for the dopamine to be in higher levels in certain areas of the brain. They stop the dopamine from passing from one area to the other. They stop the dopamine from being increased in areas of the brain. And technically, if that is what it's doing, then the dopamine in certain areas of the brain is being reduced, which is kind of what we need to do in order to treat the symptoms. But the problem is the first generation drugs, the 1950s ones, they would block the dopamine receptors for a longer period of time. Now, it's okay to block the dopamine so that, it's reduced and it goes down to a normal level, but blocking it for too long is not natural, and that would cause some side effects. Two particular side effects that would be the result of these typical antipsychotics would be extrapyramidal syndrome and tardive dyskinesia. I know these are terms which will be very difficult for you to remember and spell, so we can just learn the abbreviation EPS and TD. Now, what are these side effects? These are basically things like facial spasms, muscle spasms, involuntary movement, shaking, etc. So these would be some side effects of the first generation drugs. The newer 1990s atypical antipsychotics, the second generation drugs, work the same way as the first ones, but the difference is they block the dopamine intermittently, so for shorter periods of time. So they work the same way, but because they're not blocking the dopamine for longer periods of time, there are fewer side effects. So EPS and TD, these side effects that were there with the first generation antipsychotics, they're not an issue with the second generation antipsychotics. And they tend to work better on people with treatment resistant schizophrenia. Now, treatment resistant schizophrenia would be people on whom drugs are ineffective. So sometimes you build tolerance, or sometimes the drugs don't work. So the first generation drugs perhaps would not always work on everyone with schizophrenia, but these second generation drugs have a higher chance of working on these same patients on whom maybe the first generation drugs were ineffective. Randomized controlled trials were conducted to test the effectiveness of these drugs. Randomized controlled trials would be randomly allocating participants to either an experimental group or a control group. And it was a double-blind placebo-controlled technique, which means the participants would be randomly allocated either to the antipsychotic drug condition or to a control group where they would be given a placebo, which is like a fake drug, like a saline solution or something. Now, the patients are patients with schizophrenia, and half of them are going to be randomly allocated to the antipsychotic condition. The other half are going to be given the placebo. And neither of the two know that there is a placebo condition, so they're blind to it. And the researchers also are unaware which group is being given what. So it is a double-blind technique to avoid demand characteristics and researcher bias and increase validity. The results showed that after 4 to 6 weeks, there was a 50% improvement in the participants' conditions who took the antipsychotics. 30 to 40% showed partial improvement, and only around 10% showed little to no improvement. So those 10% were the ones who had treatment-resistant schizophrenia, but majority participants did see a decline in their symptoms after taking the antipsychotic drugs, much more compared to what we saw in the placebo condition. However, some issues are that there are relapse rates because people only take these drugs when they're going through certain psychotic episodes. And once the episode is over, because it's a short-term solution, right? It's not a long-term solution. You go through a psychotic episode, you want a quick fix, you take the drug, it might help you, but that doesn't mean that you've resolved the issue. You haven't cured yourself. You've just treated yourself temporarily. And there are many other side effects as well. Weight gain, drowsiness for the first generation drugs, EPS, TD, and other types of disorders, or not disorders, symptoms or side effects that you can experience. So in terms of its application, yes, it's useful because it's relatively quick to take, less time consuming, but overall application would be low because you can only get these drugs with a prescription from a psychiatrist, and there can be certain side effects of the drugs as well. And it may not necessarily be effective on everyone. It might be, if you have treatment resistant, it might not work on you. And there are, of course, chances of relapse. In terms of nature nurture, this is definitely more nature because it's a biochemical treatment, okay, focusing on reducing dopamine, which is biological, in order to treat you. Um, Is it deterministic or free will? A bit of both. You can choose whether you want to take the drug or not, but the effect that the drug is having is deterministic. You're not choosing whether it will have a strong effect on you or not. In some cases, it may not work at all. So that's not something that you can necessarily control because everyone's biology, everyone's physiology is different. So that's deterministic. It's also reductionist because it's just one way of treating you, okay, which is reducing dopamine levels. It's not accompanied by any form of therapy or any other sort of treatment either. So it's definitely reductionist. Validity is there because it's a randomized controlled trial. So we're comparing placebos to RCTs with a double blind technique. So reducing demand characteristics, reducing researcher bias, and it's giving us quantitative data, the percentages, right? So that's something we can use to compare the effectiveness and how effective it is on different people. And because it's working differently on different people, it's favoring the individual explanation. Okay, it doesn't, everyone's in the same situation. Everyone who's in the antipsychotic drug is getting the same drug for the same period of time, but it's having a different effect. It's 50% of the participants are going through a huge improvement, 20 to 30% partial, and 10% have no improvement. So obviously individual differences. Everyone's physiology again is different, so it works differently for different people. The second biological treatment is electroconvulsive therapy. Now, this isn't your go-to treatment. This is more of a last resort because it's a very risky and dangerous treatment technique. So if you have tried every other technique, therapy, drugs, you've got treatment-resistant schizophrenia, then maybe you can consider this one. This is a form of biological treatment that involves passing electricity through the brain in order to induce seizures. So you're actually giving electrical currents, passing electricity in the brain. Your brain has two hemispheres, the left and right. So either we do it unilaterally, which means we pass electricity in one half of the brain and then the other hemisphere, or bilaterally, which means both hemispheres at the same time, which could be a little more dangerous. So it depends. But either way, you are inducing seizures. You're causing seizures to the participant. And again, we don't have too much evidence as to why, but this apparently helps to reduce the symptoms of schizophrenia. This was initially tested on cattle in 1930s and modified to be tested on humans, but they were not given any proper anti-anxiety drugs or precautionary measures were not taken. So it was very dangerous. People would have neurological or brain damage, memory loss, broken bones, and sometimes it could even lead to death. Modern ECT is a lot safer. It starts with giving the patient anti-anxiety drugs so they're completely relaxed. You can undergo around 6 to 12 sessions of it or fewer depending from patient to patient, typically given twice a week. It is applied either unilaterally or bilaterally, where electricity is passed either through one hemisphere or both at the same time. And that can lead to short-term memory loss. Okay, it has its risks. It can cause neurological damage, maybe even death, but that's in an extreme case because modern ECT is much safer. It cannot be self-administered. It has to be done so with the presence of an experienced individual who knows how to run this. Um, Rare side effects include neurological damage or even death. So it's not your go-to technique. It's a last resort. Um, it's definitely biological in nature, so it's not nurture at all. You're not learning anything over here. There's no environmental influences. It's pure biological. It's definitely favoring the nature side because electricity is being passed or induced into the brain to induce seizures, which are then helping you or trying to treat your condition. Um, what else? In terms of ethics, it's not the most ethical, so application is very low. That's why it's a last resort. It's very risky, it's very dangerous, so the application isn't very high of this. Um, it can work differently on different people, different side effects. Okay, some it can be riskier on some people, not so much in others. So it's definitely individual. And yeah, so again, some evaluative points for this. And typically, it's more useful for people with severe symptoms rather than minor symptoms. Okay. Um, and the last one, the psychological treatment, CBT, cognitive behavioral therapy. This is a form of therapy that aims at changing your cognitions or your thoughts in order to change your behaviors. So immediately it's focusing not just on thoughts but also on behaviors. So it's a more holistic approach compared to the biological techniques. Um, Again, linked very closely to the cognitive or psychological explanation. Frith told us that, it's got to do with your thinking. So if your thoughts are the reason for your schizophrenic symptoms, such as auditory hallucinations or delusions, then the aim would be to change your thoughts, to alter your thoughts, and to make you think in a more logical and rational manner. And if you are aware of this and you're able to alter your thoughts and think in a more rational manner, that might allow you to reduce your symptoms. So you have somewhat of a control over here over your thoughts that you can change, which might then alter your symptoms and reduce them. So immediately we can consider the role of free will over here. So CBT is a form of therapy for treatment of mental disorders that incorporates both the behavioral approach as well as the cognitive approach. So again, changing your thoughts to change your behaviors. It is a form of talking therapy between the therapist and the patient. And you try to understand the origin of the behavior, and then you try to treat it. It helps reducing distress, disability, and hospitalization. And some people who do not respond well to medication, some people who are looking for a more long-term solution, a more permanent solution, might go for therapy because medication is more short-term. Medication has side effects. Therapy does not have side effects. Therapy can maybe overcome the issue altogether because it is more long-term. Medication might just help you in the short run. So this has its pros and cons, which we'll discuss once we evaluate this. So let's take a look at this. A study is carried out by Sinsky in 2000, again using randomized control trials, where participants are allocated to one of two conditions. So all the patients are patients who have treatment-resistant schizophrenia, and they're either allocated randomly to the CBT group or to a control group, which would be the befriending group. So let's take a look at what's happening here. Befriending involves one-to-one sessions or discussions about hobbies, sports, and current affairs. So those schizophrenia patients who are randomly allocated to the befriending condition in the study would be with an experienced nurse, and they would just be talking about general topics such as hobbies, current affairs, sports, and random topics. So befriending means literally socializing. So they're not really going through any particular therapy as such. Okay. There were a total of 90 patients, 16 to 16 years of age, all diagnosed with treatment-resistant schizophrenia from 5 different clinical services. Each went through 19 sessions of either CBT or befriending, depending on whichever one they were randomly allocated to. Those who were randomly allocated to the CBT condition, that was also conducted by another experienced nurse, but let's see what they're going through. The CBT treatment involved the patients engaging with the nurses to discuss the emergence of their disorder before tackling specific symptoms. So first, the doctor or nurse is going to actually talk about how the symptoms start in the first place. So what are your symptoms? How did they begin? Is there a cognitive origin for it? Has it got anything to do with your own irrational thinking? Remember, abnormality of self-monitoring that Frith discussed. What was it? Misinterpretation of perception. So incorrectly perceiving your thoughts as being as being external rather than internal. So trying to help you understand the origin, because if you're aware of the fact that maybe this is a cognitive issue, and it's got something to do with your thinking, then once you create that awareness, then only can you change those thoughts. Then only can you tackle the symptoms. So for example, patients who suffered from auditory hallucinations were made to go through something called a joint critical analysis, which means both the nurse and the patient would together critically analyze their thoughts. So if you're going through, auditory hallucinations, you're hearing voices, we will kind of almost challenge the origin of these voices. Do you genuinely believe that they're external, or do you think there's a possibility they could be internal and come from your own head, from your own mind? So together, the therapist and the patient will talk about this and try to make the patient realize that this might be internal rather than external. So we're challenging the origin of these symptoms. Patients were encouraged to keep voice diaries. So, even outside therapy, every time they felt that they're hearing voices, they record them, and then we can discuss them at therapy, and we can come up with coping strategies to help you deal with these and make you realize that they might be internal rather than external. So blind raters would assess both the groups at a couple of phases. Once at the beginning of their treatment, then once at the end of the 19 sessions, which would be 9 months. And then at a further 9-month follow-up to see the long-term effectiveness of the treatments that the groups are going through.
How are they getting assessments of their symptoms? Through two questionnaires. One is called the CPRS and the other is called the SANS. So through these questionnaires, the raters are going to be rating, and when we say blind raters, that means the raters do not know which participant is in which condition. So through these assessments, um, the raters are going to be rating positive and negative symptoms, because that's what these two questionnaires are used for, to assess positive and negative symptoms of schizophrenia. So through these questionnaires, through these assessments, the raters are going to be assessing the 90 patients in terms of any positive and negative symptoms that they may be displaying. Once at the beginning of the treatment, so we have a baseline to get an idea of the severity of their positive and negative symptoms. Then once at the end of the 9-month period, to see if there's any improvement in positive and negative symptoms, and which group had a greater improvement, the CBT group or the befriending group. And then at a further 9-month follow-up, once the treatment stops, to see the impact of the treatment in the longer term. Okay. The results showed that both groups showed a significant decrease in positive and negative symptoms. So from the first time when they began the study up to the 19 sessions once they were ended at 9 months, both groups actually showed a significant decrease. However, at a follow-up stage, the CBT group continued to show a decline in their positive symptoms. So if you compare the befriending condition to the CBT condition, both at the end of 9 months show the decrease in their symptoms, but the CBT group, once treatment stopped, continued to experience a decline in their positive symptoms, suggesting that CBT has a better long-term impact than befriending. Let's take a look at the exact numbers. From 46 people allocated to the CBT group, 29 patients showed 50% or greater reduction in symptoms in the CPRS scale, which is positive symptoms, and 23 showed 50% or greater reduction in symptoms in the SANS scale, which is negative symptoms, at the 9-month follow-up period. But for the 44 patients in the befriending group, only 17 showed 50% or greater reduction in positive symptoms, and 23 showed 50% or more reduction in negative symptoms at a follow-up point. So clearly, the results are showing us that those in the CBT group had a greater reduction in positive symptoms compared to the befriending group at a 9-month follow-up. Okay, so for the evaluation of the psychological treatment, it's definitely free will, because you have the choice to change your thoughts. Yes, it's being done with the help of an experienced therapist, but you, at the end of the day, are acknowledging that even though the disorder might be out of my control, it's deterministic, at least the cause, I can choose to change the symptoms by choosing to change my thoughts. I can acknowledge, I can learn, I can deal with these symptoms through coping strategies, through recording in voice diaries, through the help of a therapist with joint critical analysis, that I can acknowledge that these thoughts might be internal rather than external, and that can help me overcome positive symptoms such as auditory hallucinations, and not only in the short term, but even over a longer period. So this is more of a long-term solution than drugs. So there is greater application here. There is less, it's something that does not have any side effects. So again, more application. Um, it's not a short-term solution. So it's effective on people with treatment-resistant schizophrenia on whom drugs were ineffective. So a lot of application. The only reason application would be low is people may want a quick solution rather than a long-term solution. Not everyone is open to therapy. Cultural differences. In some cultures, it may be seen as a taboo to go for therapy. So people may not be open in certain cultures to therapy. It might be expensive as well. It might be time consuming. Some people might be a little hesitant to discuss their problems with a therapist. Some people might have such severe symptoms that they may not even be able to acknowledge that the fact that these thoughts are internal, and therapy may not work on them at all. So maybe drug or antipsychotic drugs are the only option for them. So application can go both ways. But in terms of nature nurture, this is nurture, because you're learning a technique, you're learning coping strategies, you're learning to overcome your symptoms by changing your thoughts. Okay, there's a cognitive element and a behavioral element. By changing your thoughts, by acknowledging that your thoughts are irrational and fixing them with the help of a therapist, changing them with the help of a therapist, you are changing your behaviors. You're no longer experiencing positive symptoms. So it's definitely nurture. Okay, and although it might be a little reductionist because it's focusing just on the thoughts, It's slightly more holistic than the biological treatments, at least, because it's both cognitive and behavioral. So it involves two elements. So I would say it's holistic. Okay. In terms of some research method terms, it's valid because there is a double blind. Sorry, there is a double blind technique where neither the raters know which condition the participants in, nor do the participants. There is a It's a randomized control trial, so randomly allocating participants. So validity is there. What else do we have? Quantitative data, so you can compare the results of the two groups in the short term and in the long term. Um, Questionnaires are being used, assessments are being used, such as the CPRS and SANS, to provide us with a valid tool to get the data to compare the results. Okay. Um, any other point that I might want to make about the evaluation? I guess that's pretty much it. So, on that note, we can conclude the entire chapter of schizophrenia. And of course, if anyone has any further queries, questions, please feel free to reach out to me on WhatsApp. As always, link to my WhatsApp groups in the description below, and access to these slides and these notes in the Google Drive that you will find in the description of these WhatsApp groups. So feel free to join and feel free to reach out to me if you have any questions. My contact number and my email ID are present on the first slide of this presentation. So hope this was helpful. Thank you very much, and see you next time with more videos on clinical psychology. So take care, everyone. Until next time. Bye bye.